Good afternoon, and thank you for joining yet another Superior Health Quality Alliance Roundtable conversation. My name's Kim Heft. I am joined by my colleagues, Janae, Jerry, and as well as our guest speakers today, we have Yvonne Burston and Mia Croyle. Just to give you a little bit of background, we host these 1-hour sessions on the second and fourth Wednesday of the month. The first half is a didactic presentation, and then the remaining time will be for question and answer. Momentarily, we'll put the link for the PowerPoint presentation in chat. And please use that chat box to share comments, questions, anything that pops into your mind during the presentation, and we'll use that for our discussion later on. We're also going to put an evaluation link in chat, and that's going to be towards the end of the presentation. Only takes about 1 or 2 minutes to complete, so we'd really appreciate your input for that too. Now we have 2 presentations today. The first one is going to be presented by Yvonne Burston. She's a Superior Health Quality Improvement Advisor. She's going to be providing an introductory presentation on the influenza vaccine. And then Mia Croyle, also with Superior Health, will be doing today's feature presentation, Naloxone Use in the Nursing Home Setting. Now, 2 announcements before we do get started. Our next event is on September 13th. Our guest speaker is Barbara Resnick, professor at the University of Maryland, and she's going to be presenting on influenza and COVID-19 vaccination for older adults. Perfect timing for the upcoming influenza season and the scheduled late September, early October release of that updated COVID-19 vaccine. The other announcement I'd like to make is that Superior Health has released new Frontline Forces modules, and it can be found using a link here that you're going to see here in a second in chat. Jerry's going to put that link in there. Frontline Forces. Now, these learning modules are for frontline staff. Some pertain to all frontline staff, others are for licensed staff. Most of the modules have a quiz for the learner to test their knowledge. You can use this for plan of corrections, maybe your annual learning for your staff. And new releases just in time for vaccination season include a series on injection safety. We also, new to our library is a module on Candida auris, and also talking to your patients and residents about antibiotics for bacterial and viral infections. Those are just a few newer ones, but we also have an extensive library that you can access through that link. Okay, so enough for all the announcements. Let's get started with our presentations today. Yvonne, go ahead and start us out.
All right. Hello, everyone. As Kim said, I am your Dr. Yvonne Burston. I am a Quality Improvement Advisor for Superior Health. Next slide. So today our objectives are to talk really quickly about influenza vaccine rationales, frequently asked questions, how well does the flu vaccination work before an outbreak occurs, and symptomatic or infected patients. Next slide. So first, the flu virus are constantly changing. The composition of the U.S. flu vaccines is reviewed annually by the United States Food and Drug Administration. Vaccines and related biological products advisory committee, and updated as needed to best match the flu virus most common during the upcoming year. The 2023 season for the U.S. flu vaccination will contain an updated H1N1 PDM component. Now, for last season, people who were vaccinated against the flu were about 40 to 70% less likely to be hospitalized because of flu illness or related complications. So that's one of a really good reason to have your residents or people you know get the flu vaccine. Next slide. So we have frequently asked questions, and we see these questions every year. So we're just going to go over them right quick. The first one is, can a flu vaccine give me the flu? And the answer to that is no. A flu vaccine cannot cause you to have the flu illness. However, the virus in the flu, there is the virus in the flu, but that virus is killed or inactivated. So you cannot get the flu from the shot. However, you may experience some side effects, which are usually mild and short lasting, especially compared to the symptoms of the actual flu. Some minor side effects that may occur are soreness, redness, and or swelling where the shot was given, headaches, fever, low grade muscle aches, nausea, and fatigue. So the flu vaccine is produced by private manufacturers. So supplies depend on the manufacturer. During the 2023 season, vaccine manufacturers projected that they would supply the United States with as many as 173 million to 183 million doses of the flu vaccine. And so we're looking for around that same amount this year. Next slide. So the flu vaccination will become available to long-term care facilities beginning in September, and the influenza vaccination should be offered by the end of October. You should have an informed consent. Those are required, but you do not have to have the informed consent at the time. They're with you when you give the vaccine. So although the vaccination should be given by the end of October, that is the recommendation, you can still give the vaccination after that time. So if need be, you can give it all the way up until March. So the recommendations for the residents who are admitted after the influenza season, if a patient is admitted, then you still should talk to them about the vaccine, and you also should continue to have them complete the consent even after that time so that they'll be ready for the next season. Next slide. So what happens when you have a resident who may have symptoms? You want them during the period of increased acute respiratory infection in the community and they're having coughing or other signs, you want them to wear a mask. And you want them to wear a mask until they're put into a private room or until they're put into a room with someone else who has the illness as well. The patient does not need to wear a mask while they're isolated, except when being transported outside of the isolation. And you also want to make sure that you use standard precautions. And sometimes you may want to consider using even more than the standard, but you want to also use droplet precautions. If you decide to use droplet precautions as well, you want to follow the CDC's recommendations. And that is going to be it for today. Any questions? All right, that's it, Kim.
Okay, thanks. Thank you for that introduction, Yvonne. Just again, trying to get this influenza season started. Hope we don't get hit hard for this fall coming up, but you never know. It's good to be prepared. All right. I'm going to stop sharing my screen so that we can get on to our second presentation. Maybe we got, all right, looks good. Okay. Yeah, Croyle, you are up next for naloxone use in nursing home settings. The floor is yours.
Okay, great. And thank you, Kim. And thanks, Yvonne, for that great information. I took my kids for their annual exam yesterday, and the pediatrician gave us exactly the same information, saying there's going to be a COVID booster coming and the flu shot. Make sure she had me put it on my calendar to get the kids in to get theirs. So definitely starting to get that message out. And we just want to be sort of beating that consistent drum of, protect yourself and get your vaccines. So I'm going to talk with you a little bit today about naloxone use in the nursing home setting. Let's see if I can get my slides to advance. All right, so just a couple objectives for our time today. Hopefully by the time we're done, you'll be better able to identify signs of opioid intoxication and overdose. We're going to talk a little bit about how to administer those rescue medications for opioid overdose, and then utilize best practices in the nursing home setting regarding that rescue medication. There's a lot sort of happening in this space right now because naloxone has just been approved for over-the-counter use. And we haven't seen it hit the shelves yet, but it should be coming shortly. And we don't know exactly what the price point will be like, but that will definitely increase the availability of naloxone just out in the community. And I think that's definitely a good thing. So what is the risk? Why do we need to think about rescue medication for opioids? So really anyone who uses opioids is at risk for overdose. They don't have to necessarily be someone who has a substance use disorder or who is misusing their opioids in any way. Just anyone really who's using opioids at some point could be at risk for an overdose. We know in particular things that increase that risk is higher doses, and also combining that with alcohol or certain other medications, other sedatives, other things that cause respiratory depression can increase your risk of opioid overdose. And we know that there are chronic diseases that involve the respiratory system, asthma, COPD, et cetera, as well as acute respiratory illnesses that can increase that risk of opioid overdose. So thinking about COVID, thinking about influenza, those kinds of infections can also increase our risk of opioid overdose. So what are some signs both of intoxication and then also of overdose? So signs that someone might be high or over medicated on opioids appear generally like intoxication. Their speech may be slurred, they may stumble, stagger, have unsteady gait, may have pinpoint pupils, they may look really sleepy or drowsy and just have those less reactive pupils that are smaller. Their breathing is going to be slow and shallow, and their heartbeat is slow. They may have unusually low blood pressure as well. Signs of overdose. We think about the acronym BLUE, right? BLUE. And the B is for breathing, right? So we've got, they may stop breathing completely, or their breathing may be abnormally slow, shallow, erratic. You may hear some gurgling or snoring type sounds with their breathing. The L in blue is for lips. One sort of classic sign is blue lips, fingertips as well. However, we want to make sure that we don't look at that as the only sign, because depending on skin tone and natural coloration, also depending on do they have their nails painted, are they wearing lipstick, that can obscure that symptom. So that is a classic telltale symptom, but it's not the only symptom that you will see. Also, the U is for unresponsive, right? So people don't respond to your verbal or physical stimulation. And then the I's also, right? So definitely in an overdose, you're going to see those pinpoint pupils. They don't respond to changes in light. They're just sort of stuck in that pinpoint um, spot. So at that point, you would consider rescue medication. So naloxone is the generic term, and it is an opioid antagonist, which means it attaches in the brain to the opioid receptors, and it basically kicks the opioid receptors out of that brain's area, and it blocks those effects of opioids. So what you're seeing in an overdose is those opioids are hijacking the respiratory center, and that causes the changes in breathing. It causes it causes low oxygenation. And so naloxone can interrupt that process, and it really does save a life. If someone has stopped breathing or is not oxygenating appropriately due to an opioid overdose, a dose of naloxone can stop that in its tracks and help you revive the person and get them the ongoing help that they need. One of the positive things about naloxone is it really is safe. So if you're unsure whether a person is overdosing on opioids, giving a dose of naloxone will not cause them any harm. They may have a little sniffles or runny nose if you administer the nasal version, but that's the worst of it, really. So thinking about having opioids on board, I mean, we have EpiPens and we administer those, and those are more dangerous than naloxone. Those have more risks associated with administration than naloxone. So currently, the naloxone comes in 3 different FDA-approved forms. There's an injectable, and this is most often used by medical professionals. Then there's the auto injector, which is again an injectable, but it's pre-filled. So you're not drawing it into the syringe, figuring out a dosage and dispensing it. It's just automatically filled, and you deliver the injection, and then it retracts the needle back into the device, almost like an EpiPen. And then the third is the prepackaged nasal spray. Currently, it goes by the brand name Narcan. I think we will see new brand names when we get the over-the-counter formulations. So there may be some new names associated with it as well. And that is a pre-filled device. It's needle-free. It's a nasal spray, and it comes completely assembled. All you need to do is take it out of the package, insert it into the nose, and dispense it. The positive thing is you really don't require a lot of training to administer that correctly. If you can give an Afrin nose spray or allergy nose sprays, you can do this. And there's no risk of accidental needle sticks as well with the nasal spray. So generally, we try when we see someone that we suspect may be suffering from an opioid overdose, we try to get them to respond. So shake and wake. We could gently shake and shout them, touch their face or ear, and then progress to a sternal rub. We definitely want to call 911. Your facility may have certain policies or procedures in place. In fact, I'm sure they do, about calling 911. So it may be contact director of nursing, and they're the ones who make the call about whether you call 911. Follow your own internal policies, but generally with an opioid overdose, the person is going to need some ongoing emergency care, whether they had received naloxone or not. So we do want to activate that emergency response system. If you are qualified, you can give the person rescue breaths, also CPR. I will say that there is some disagreement in the sort of CPR training world about whether you should just focus on rescue breath CPR and calling 911 or take the time to get naloxone. If you have naloxone at your facility, Generally, you will have staff capacity for someone to retrieve the naloxone and someone to attend to maybe providing rescue breaths and CPR if needed. So if you're going to administer the Narcan, this is again the nasal spray. It's really simple, a 3-step process. Step 1, you want to peel the box open. You don't need to prime or test the device. That just wastes some of the dose. It's ready to go. And then you place it in the nostril and you press the red plunger to give the dose. I have a video, but I think I need to stop sharing and then reshare it because I didn't indicate to share sound. Let's see. Okay. So I think this video should work. Let me know if you are not seeing or hearing the video. Oh, what happened?
911, what's your emergency?
Okay. So it really is that simple. We talk about multiple doses, particularly if people are not getting pharmacist administered opioids. There really has been a large number of opioid deaths due to inconsistent dosaging, particularly fentanyl. And there's a new one, xylazine, I think. I might not be saying that right. And those medications or those substances are mixed in with other opioids that might be bought on the street, and they really increase the potency to a very, very high level. And at that point, people tend to need multiple doses of the naloxone. If the overdose that you're dealing with has dealt with, is coming from an opioid dose that was pharmacy dispensed, you probably don't have to worry about that as much. And so one dose may suffice. However, there's no harm in administering more than one dose. You want to wait and give it, like the video said, 2 to 3 minutes to show any effect. But if you're not seeing any effect after 2 to 3 minutes, you can certainly try a multiple dose. So some guidance for nursing home facilities. We have facilities should have a written policy that deals with their policy on opioid overdoses, so addresses that. And facility staff should have some knowledge of the signs and symptoms of possible substance use in general, and they should be prepared to address an emergency or of an overdose. We want to think about increasing monitoring, administering naloxone, initiating CPR as appropriate, and like I said, contacting those emergency medical services. So your staff should be prepared to really do all of those things. This is the regulation that sort of relates to that. And the CDC has issued additional guidance, sort of spelling out what some of this should look like. So the facility must ensure that pain management is provided, consistent with standards of practice, person-centered care, and the goals and preferences. So there's a toolkit that has been created by one of our Quality Improvement Network colleagues, iPro, And they really, in this toolkit, have provided some wonderful templates for those policies and procedures. They talk about how to implement and improve that emergency response to opioid overdose. And the policies and procedures that are included are really designed for you to take that template, customize it to your facility and make it your own. So in the chat, you'll see a link to where you can access that toolkit. They also have a checklist available so you can sort of check in on your facility's response. How are you doing in terms of hitting all the high points, the things that need to be included in a comprehensive best practice policy, set of policy and procedures. And some areas that you may want to consider are, what are we already doing, or how are we doing on screening and assessing residents as they're admitted, and then periodically as well, for the risk of opioid overdose, also for the risk of substance use disorder. And then what are we offering in terms of staff education on naloxone? What's our policy on naloxone availability and our policy on how to use it? The other thing that is, of important consideration is not just residents, but you could experience an overdose in your facility from a visitor. You could experience an overdose on the part of a staff member. So we want to think about, how do we have naloxone? How is it available? What are our protocols around it? And then, are there standing orders in place to utilize it? And one thing that I thought was a very interesting recommendation that I hadn't honestly thought of before, that they included in this toolkit, are drills. So do you do an overdose drill? And that helps staff, as we know from our other drills, right? That helps staff increase their comfort level with how to respond, and it helps them practice those things that they've learned, so that the first time you have to, walk through those steps of doing, following our overdose protocol, figuring out what is our procedure, isn't when a person's life is on the line. So I thought that recommendation to have overdose drills was a very good one. Some additional resources that I wanted to share is through Superior Health Quality Alliance, we have a stigma campaign, an anti-stigma campaign called Shine a Light on Stigma. And as part of that campaign, there is some learning and resources, particularly focused on person-centered language, that can help us shift from stigmatizing language, and which can help us shift our culture away from one of stigma and one more toward compassionate care for all. And so there's a pledge on that website that you can take, saying, you're pledging to commit to trying to utilize this more person-centered language and encourage others around you to do it. There's also an organizational pledge. So if your facility says, yeah, this is something we really want to commit to on a facility level, you can take the organizational pledge, and that just basically talks about how you're going to promote those same things on an organizational level. We also, somehow it isn't, here. Okay, so there's the take the pledge, learn about stigma, use that non-stigmatizing language. And then there's also a promotional media toolkit, so you could publicize that you've done that as well. And we invite you to continue the conversation in Superior Health Connect. The website that's linked here, or the QR code, are ways that you can join Connect if you haven't already. But we invite you to join. So we've got some time remaining for questions, comments. I'm going to stop sharing so that we can see one another's faces. There you go. And there is actually one other resource that I want to make folks aware of. So there's a new webinar series that's coming out. It's a nationwide collaboration with all of the Quality Innovation Network, quality improvement organizations across the country. So the organizations like Superior Health is your local Quinn QIO here in Wisconsin, Minnesota, and Michigan. And we've partnered with the rest of the organizations across the country for this new webinar series. It's going to provide strategies, interventions, and some targeted solutions to ensure access to medication for the treatment of opioid use disorder and facilitate the continuity of care throughout the continuum. We're going to have national experts speaking monthly. And that series is going to be on Fridays, starting in September of 2023, running through June of 2024. And it's going to be at noon Eastern time, which is 11 a.m. Central time, 10 a.m. Mountain time, and 9 a.m. Pacific time. So across the country. So I think someone is putting the link to register for that as well into the chat. So if you're interested in that, there's a flyer and the information on it right there in the chat. And we have other stuff in the chat. We've got lots of resources in the chat. So I am curious to hear from those of you on the call, and you can just share this in the chat as well. What does your facility currently do around opioids? Do you screen? What do you have in place for rescue medications? Do you have any policies and procedures? Do you have naloxone or Narcan on site? We'd love to hear what's currently happening in your facility. So please just share with us what's going on where you are into the chat. Or you can unmute yourself and just participate that.
Mia, while we are waiting for a response, is there a difference in response time if someone receives the nasal Narcan versus an IM injection of the naloxone? Is there a difference in time?
I have not seen anything with there being a significant difference in time. There may be a little, but it's not going IV, so it's not the same level of, immediacy that you would get if you were administering it IV, just providing it IM. There doesn't really seem to be much of a difference. I think there might be a little, but not so much that it significantly matters.
And I just had a quick question about if someone's not responding within 2 to 3 minutes, for a non-clinical person, what does that not responding look like?
So they would probably still be unconscious. They wouldn't have started breathing. Their breathing would still be not there. So they still would be not breathing. That's what not responding would look like. Oftentimes what the response looks like is, you may have seen this dramatized. It's been on, some shows, but it's actually fairly accurate. Usually they gasp and then start breathing again because essentially their body's been deprived of oxygen. So when it starts breathing again, they go, and then they start breathing again. When someone is first revived, it tends to be a little disorienting for people. So, if you imagine if you had just passed out and stopped breathing and then you come to, it tends to be a little disorienting. I think there is, and I've heard this, a big fear among some people that they're going to wake up and be violent. That tends to be very rare that someone is revived and I mean, they may like want to sit up and start and try and walk away or something like that, but it's more from disorientation than aggression. Um, and what we tend to see is if you can just, provide some calm reassurance to the person, let them, they can go into that, if you can get them into that recovery position sort of on their side to help support their breathing. Those are the best things, just giving people space. We don't want to try to like restrain a person or anything like that, but just kind of giving them a little space and giving them a little reassurance and saying like, hey, I'm so sorry, you might be feeling kind of yucky right now. The one thing it will do is block any opioids. So if someone has become if their bodies are physically accustomed to opioids, which is common, that's not necessarily a sign of substance use disorder. It's just a sign of opioids tend to, your body acclimates to them really quickly and gets used to having them on board. So they might instantly start to feel some withdrawal symptoms, which are pretty uncomfortable. So that may be, something someone, they'll feel like kind of like the worst flu you've ever had in your life. So yeah, just sort of giving people, I'm sorry, looks like you're feeling pretty awful. We had to give you some naloxone because it looks like your medication was interacting in a not great way and you stopped breathing, but you're safe now. We've got you, giving those reassurance and simple explanation is really the best way to welcome someone back. Yeah, Tabitha, it may be somewhat similar to when a person with diabetes comes out of a low blood sugar incident and they're sort of, once they get, back to sort of baseline. Yeah. So John is putting in the chat some additional, like the clinical opiate withdrawal scale. We're not saying that in a nursing home facility you would use that necessarily, but that is why. The other thing that's important to think about when we encourage you to activate the emergency response system and get some first responders on board is the rescue medications have a fairly short duration, so 20 to 30 minutes. And depending on how high the dose is that's in their system, it sort of like waits out the naloxone, and then sometimes people will return back into that overdose state. So they may lose consciousness again, they may stop breathing again once that initial dose of naloxone wears off. So it's not like once you've given them a nasal spray, they're good to go and you can just let them return to their usual day. We really do want to have a thorough assessment and workup done with that individual. And Kim asked in the chat, does anyone on the call have a naloxone policy? Or standing orders? Yeah. So I don't know about in our 3 states in particular, but I do know that state surveyors are starting to look for these policies. So I think this is definitely something that's coming. And again, like I said, I don't know in particular about these states, but I've heard from other states that they are definitely, state surveyors are looking for these policies when they go in. So I would really recommend checking out that toolkit, looking at the policies. It feels initially pretty complicated, but when you look at the policies that they have in the templates that they have in that toolkit, it really can be, looks like it can be fairly straightforward. And if that's something that folks are interested in, please let us know, because we can certainly think about some support and some resources to walk through some of those policies with you. We could have a follow-up call looking more closely at those policies. Yes, prescribers are now it's been really recommended that they co-prescribe naloxone when prescribing opioids.
Yes, I do highly recommend that toolkit. And it does even indicate in the toolkit, you'll see that in the State Operations Manual, Appendix PP, page 338, there's a whole section here now on SUD, that the facility, they need to be prepared to address emergencies related to substance use by providing increased monitoring, maintaining and having knowledge of administering opioid reversal agents like naloxone, initiating CPR as appropriate, and contacting emergency medical services. So there's more. I'm not going to read the whole thing, but I highly encourage everyone to read this section, so that then you can go from there and figure out what it is that you need to do in your facility to abide by the state operations manual. Good toolkit, by the way. Yeah.
Yeah, I found it to be a great resource. So I encourage you to take a look at it and let us know how we can help.
One of the things that I really wanted to have some light shed on is when we talk about CPR or Code Blue initiatives within the facility or in the hospital setting, it is very clinical driven. With this rescue medication, how does the non-clinical person get involved, and how should facilities think about that in their policies?
I think that is dependent on the individual. You're right, on the policy. And when I think about anything that's emergency CPR, who is trained in CPR, who is trained in rescue breathing? If you are not, then you shouldn't be doing that. But nowadays, so many people, especially in the nursing home setting, doesn't matter if you're a dietitian or a housekeeper, so many people are involved. I mean, now have CPR training that could be initiated. And I think that would still apply here until that nurse shows up, or whomever is now the second person and says, I have this now, I'm relieving you. I think that would still fall true under this emergency situation too. Maybe something I would add in would be the acronym for Blue. Maybe not everyone knows that. Maybe that is something that could be posted in areas or part of some form of annual training, that Blue acronym to look at for someone that possibly could have an overdose.
Absolutely, because then everyone can really be your eyes and ears of that, higher level professional, but they can't be everywhere. So if everyone is trained to notice that Blue, those 4 key symptoms, you would have, sort of eyes and ears everywhere to be keeping an eye on residents. And, some of it, exactly, it may be that a nurse is going to be the one administering, but if you have the naloxone locked in a med box that only the med nurse has a key to, that sort of might hinder your response, because if the nurse is engaged in giving CPR and sort of running the code, they can't send someone else. Well, they would have to stop, get their keys, give their keys to someone else, and send someone else to go fetch the naloxone, as opposed to having it available somewhere where everyone knows where it is and it's readily accessible to people. So just, you know, thinking through some of those things, like in an emergency, who's administering CPR? Who's going to go get the naloxone? Or do people, you know, I do a lot of trainings in the community, and several of the people who are people in recovery who participate in the training have they have their nasal spray on their keychains, you know, so it's just that accessible to them. It's not, you know, a drug of abuse in any way, so it's not like we have to necessarily, we want to make sure we always have a dose on hand, so if it walks off, we have a system to replace it, but it doesn't have to be under lock and key necessarily, because there's no risk or no harm. So sort of what's the over under of keeping it locked up somewhere versus having it more readily accessible to anyone? But yeah, those are the kinds of questions that we would want to think through as you decide what your particular policies are. And there's no one right way to do it. But if you don't have a policy, that's, I guess, the worst, because then you don't know what's going to happen when an emergency arises. Other thoughts from folks, questions, concerns? And like I said, with it now coming out as over the counter, it's been available for anyone in all of our states for a while. All pharmacies have a standing order that you can go and just request naloxone. The real issue has been financial accessibility, because it's not cheap to just go get it. But anyone can go get it, and there are some programs that dispense it free of charge in all of our states as well. So in addition to policies that think about what do we do with the facility provided naloxone, do you have a policy if your staff are carrying naloxone just as an individual? If they have some in their purse, what is your policy about them administering that? If if a visitor has an emergency or something like that, how do you, so just making sure that all those things are thought through in advance, because you certainly, like I said, the time to think through and practice those things is not when someone's life is at stake.
Any other questions, comments? No, that's all right too, though. That's
Yeah,
okay.
I appreciate your attention to this, and please do fill out the evaluation. Let us know if this is a topic that you want to hear more about. You can either let us know in lots of different ways. You can reach out to us at Superior Health, or you can put it on the evaluation. If this is something you want to hear more about, like I said, we can provide you with ongoing support in these policies and developing this in a lot of different ways. Thanks, Kim.
Yeah, thanks, Mia. Again, yeah, great presentation. We always enjoy having you here. Yvonne, also, thank you for doing your presentation on influenza vaccine. Appreciate you too. Appreciate the audience for being here. Thank you for all of your input. Again, another amazing session. Please fill out that evaluation form. Tell us what you think about today's presentation, and if there's anything you'd like to see in the future, be greatly appreciated. And with that, I hope to see all of you next time. I believe I said that was September 13th is our next time we get together again. So with that, everyone, have a great rest of your afternoon.